So next point would be, how do we choose TFR candidates in the U.S.? I think you've kind of heard that it's ready for prime time, but we have to be careful. So just to highlight again this list and to point out that the patient specifics in the U.S. are to be taken seriously. We don't recommend at this point patients with prior AP or BPCML, patients with prior resistance. I think that's a question on the table, as Dr. Hughes pointed out. You need to have good access to monitoring, and you need to have a stable deep remission. How long you decide and which patient you choose is probably a decision between clinician and patient, but I think we're clearly getting better evidence with regards to length of TKI treatment and length of deep remission being more favorable and important. But these are key elements. The monitoring rules, I think, are fairly intuitive, where you want to not give up the pace with monthly monitoring for 6 months and then 2 monthly monitoring through 24 months and then continue to monitor. And the resumption rules are, I think, been adapted pretty much globally, where we view some of the fluctuations in low-level PCR positivity not as necessarily reason to restart therapy, but loss of MMR as being very important. And then lastly, the need to kind of centralize some of the assessments through CML specialty centers and to report any adverse events, because we're still learning about withdrawal syndrome, and of course we want to hear about progression events. Lastly, to better predict which patients might be successful. I think we heard the summary statement that NK cell populations may be relevant. This is just some of the data, courtesy of Delphi and Ray. In the STIM trials, patients had careful assessment and immune function testing with their treatment-free remission follow-up, which I think has given us some nice data. In this study, the prognostic factors for molecular relapse, aside from the clinical ones, which we knew, which would be so-called risk, duration of imatinib, there were some differences in age and sex and interferon, although those haven't been borne out across, reliably in other studies. The circulating mature NK cell fraction seems to have been a fairly strong predictor in this analysis. And in a multivariate analysis remained significant. So this may help us, again, to move past the coin toss with the patient who is thinking of embarking on a treatment-free remission. This data is correlative to data from the EuroSki trial, which is the largest of our treatment-free remission trials, which, as Tim had reviewed, had some of the least stringent criteria. And again, there was lymphocyte subset fraction analysis for patients who were on part of the sub-study. And we can see the NK cell proportions differed between patients who had late relapse or did not relapse. They were higher than the healthy controls or early relapse patients, and the NK cell counts as well. So I think multiple studies, including the DADI study, the dasatinib discontinuation trial, if you look at the table on the right, you can see that the CD16 positive, 56 positive NK cell fraction was highly significant in this patient's predicting who would or would not relapse with discontinuation of dasatinib. So I think we have fairly consistent data. How strong a predictor it is, I think, remains to be seen. And of course, we want more than just this, but I think this gives us a place to start. And then lastly, second, treatment-free remission. I think we're going to have quite a large population of patients who may attempt treatment-free remission, particularly in the U.S. now that it's outside of clinical trials. And just give you a hint at some of the candidate therapeutic approaches. We've seen data with the PPR gamma effect of pioglitazone being able to induce a deeper remission with imatinib. And there's a small trial. It's actually run by Gene Curry prior to his passing in Atlanta. I think we'll see some data on that eventually. And there's some studies in Europe, particularly in France, looking at pioglitazone with imatinib. This drug has some other toxicities, bladder malignancies, so requires some attention with regards to development of comorbid toxicity, but is of interest. There's nice data from Javier Pernilla and Kendra Sweet from Moffitt. Hopefully they're not still underwater as well. Looking at ruxolitinib, they have a phase 1/2 trial combining the drugs to optimize molecular remission, and there's a very nice rationale by inhibition of STAT3 and STAT5 signaling where this might be helpful to engender a second treatment-free remission, and trials are being planned for that. And lastly, the vitamin D receptor agonist inacalcitol, from some nice data in France in cell lines, has really been shown to be synergistic with imatinib. And there's, again, good early data in phase 1/2 trials that
molecular response can be improved. Ergo, we may want to try this approach for patients who fail to achieve treatment-free remission, an add-on to imatinib. And I'm emphasizing what I think are very low toxicity options, because we've seen some things come and go, such as hedgehog inhibitors with real issues with toxicity, not being able to add it to patients to deepen molecular remission or postulate using those types of drugs for second TFR. These patients are going to need low toxicity approaches. So I'll stop there because I know we're over time, and thank you for your attention.